My name is Sean McCann. I'm conducting a series of podcast interviews for the European Hematology Association at the annual meeting of EHA, which this year is in Madrid, which of course is in Spain. And with me at the moment I have Vip Viprakasit, if I pronounced that correctly.
That's correct.
And Vip is Professor of Pediatric Hematology at Mahidol University in Bangkok, which of course is in Thailand. And he's an expert on hemoglobinopathies and iron chelation therapy. So I'm going to make a statement really, first of all, to say that with all the migration occurring from Southeast Asia and from Africa into Europe, we are now seeing these diseases, and we don't know very much about them. So
actually,
we have to educate our doctors.
In Europe, you call it rare diseases, right? I mean, this is thalassemia, hemoglobinopathies. You put it in the category of rare diseases. However, in the subtropical country, for example, in Southeast Asia, in India, subcontinent, and also in the Middle East, and of course in Africa, this is not a rare disease. This is the most prevalent disease in the world. And with the population migration, of course, you open up a new era of this new condition, and rare become common.
Well, as somebody said, a rare disease is only rare until you have it.
That's
and
correct.
Then it's not rare anymore.
Exactly. It's no more rare.
Okay.
No more rare.
So we know a little bit about sickle cell disease in this part of the world because people get transfused. They get iron overload. But in some forms of thalassemia, you get iron overload even without transfusion.
Exactly.
So explain that to me, please.
So at present, we classify thalassemia into two main categories. One we call transfusion-dependent thalassemia, which is the TDT. The major form is the beta tau major, and that's very common in Mediterranean countries as well. For example, like Italy, in Greece. Okay. Another form of thalassemia is non-transfusion dependent thalassemia, which is the NTDT. And this one has a broad spectrum. You can have, people with the hemoglobinopathy interact with thalassemia, such as the E-beta thalassemia. You can have C with beta thalassemia. You can have alpha thalassemia, which is, I'm the expert, hemoglobin H disease. And also, some other very specific peculiar form of, thalassemia interact between both alpha and the beta. So this non-transfusion dependent thalassemia, even though they don't get blood transfusion regularly, which is the opposite of the transfusion dependent thalassemia, but they can still have the iron overload because they increase intestinal iron absorption.
Okay. So in terms of the thalassemia patients that you see, would the transfusion-independent ones be 50% or?
Well, in countries like Thailand, I would say 70%,
so
70%.
Most of them?
Most of them are non-transfusion-dependent thalassemia, yes.
So how do you, as a clinician, assess the amount of iron somebody has on board? That's
a very good question. So normally, we do a very conventional way. We measure the level of the serum ferritin. We're looking at the transferrin saturation. So this is a standard of the iron measurement.
And that's pretty simple. Every laboratory can do that.
Yeah. However, in the more recent year, especially from the research in the past decade, it has shown that, looking just only these plasma parameter, it doesn't really seem to be enough. So we need to do a direct iron monitoring in the internal organ that seem to be a primary target of the iron overload, which is one is the liver, another one is the heart. So now we use the MRI, the magnetic resonance imaging, and do a specific calculation in order to interpret that into the milligram of the iron in the heart and in the liver. I think that's cool.
And a lot of people are doing that now, but it's not available everywhere, unfortunately.
Absolutely. Not many. In developing country, it's very difficult to have the accessibility for that kind of the program. We are very fortunate in Thailand, because I set up a program for the MRI. So we wrote the software ourselves. However, and we validate that with the world-renowned, expert in California, Professor John Wood, who also have the program that have been approved, and we also have that compare with another FDA-approved system, which is called the FerriScan. So, with this program, we can provide accessibility to the technology to people in developing countries.
So before you decide on treatment, then you need to assess the amount of iron on board.
Absolutely.
And, and does that tell you then when to treat?
Yeah, that's right.
And
so we now in the era of precision medicine, that what you call, or tailor-made medicine. So doing this precise monitoring, it will help guide our clinician, should I decrease the dose? Should I increase the dose? Should I continue? Should I switch to another chelator? So I think, this is helping in terms of the more precision kind of decision for the patient.
Right. So let's talk about chelation therapy then.
Oh, yeah,
because it's a huge problem, obviously, for children, or has been in the past anyway. What's the current situation?
That's right. Well, in the last 4 or 5 decades, we rely on the chelator, which is desferal or desferoxamine.
Yes.
And using the desferal is kind of very painful and very cumbersome, because you have to prepare the drug yourself. The patient has to inject it, put the needle, stick with your skin, 10 hours every night.
Yeah,
every night.
Nice.
So I think it's the most difficult medical treatment so far. I mean, comparing even with the other specialty, right? So in the last, I think it's nearly 10 years now, we have the new oral chelator, which is now, it's not new, it's the defracyroc, which is the once daily dosing for the oral chelator. The study has shown that it has comparable efficacy as the injection of the desferal. And also more recent data has shown that it's very good in removing iron from the liver, and also it has the efficacy removing iron from the heart as well. Okay. So the drug is now widely used throughout the world. Okay. However, one of the obstacles of this drug is that it comes as a tablet, and you have to put it in the water, stir it, dissolve it, and it's not very quite like Thai food, okay? So most of the patients, they don't like it. It's the palatability is always the problem. So last year, they have upgraded the formulation of the defracyroc. Instead of putting as the dissolvable tablet, they make like a film-coated tablet. Yes. So make it easy. In the morning, you just take it in with the water and you just go on and work.
Okay.
Yeah. So I think, the study which just published early this year is called the Eclipse trial, had shown that, with this new formulation, it have improved tremendously in terms of the patient compliance, the palatability, adherence to the drug. And I think this is very important for the long-term efficacy of the chelation.
Right. Well, when you decide that chelation is necessary, and you're now using oral chelators, how long does it take before you reduce the iron content?
Well, that's
acceptable levels?
That's a very good question. I think it depends on the several factors. The first factor is the baseline iron status in your body. So if the patient has already very loaded, it's going to take time to remove that.
Are you talking about years or?
It may years. It may take years. Okay. And the second important factor is the rate of transfusion. If you keep topping up the iron by blood transfusion every 3 weeks, we have to overcome that as well.
Yes.
Okay. And the third important thing is the chelator that you use, because people respond differently even with the same chelator.
Okay.
The dosing also very important. I mean, in some particular patient, you need to combine that with 2 chelator instead of 1. So to answer your question, it's not easy because it can be variable depending on several factors.
Okay. In terms of compliance, I mean, how do you make patients take the tablets? Because we know it's a huge issue.
That's a huge issue. That's a huge issue. And, I'm a pediatrician, and we always have the problem when they turn to adolescent.
Yes.
That's the problem. That's the huge problem. Yeah. In childhood, that's not problem because we have parents. Yes. That's my assistant, right? I mean, the parent is a good assistant to control. But when they turn to adolescent, they become rebellious.
I know.
They don't want to do it. And, they're getting better, in an early adult. However, later on in life, they have some other excuse. Work, their social life, and so on and so forth.
Yes, I
So
know.
I think the most important factor to have the patient engaged in your treatment plan from the beginning.
Okay.
Because you need to educate them that, this is for you. This is nothing to do with me as a clinician. But, we helping, we are partner. So we work together to make the best for you. Yes. And that's for your benefit.
But as you know, what doctors say and what patients hear
Yeah.
are two different things.
Right, yeah.
Okay, let's talk a little bit about toxicity, because the old-fashioned
Yeah.
desferrioxin
Oh,
is quite
yeah,
a toxic
it's
drug.
horrendous.
So in
It's
terms
horrendous.
of the oral
Yeah,
iron chelators,
yeah.
what about toxicity? Is that an issue?
So it depends on the chelator that you use. Another oral chelator that has been developed before is the diferriprone.
Yeah.
And actually the diferriprone also have very good efficacy in terms of removing iron in particular area, for example in the heart or in the brain. For example. However, diferriprone also have the side effect of granulocytosis
Not
and
nice.
neutropenia, not very nice, and arthropathy as well, arthropathies, making it a little bit very difficult to use it in a very young child,
Yes.
in infant, because they cannot speak. They cannot complain.
Of course, they can't complain.
Right? Yeah. But, after, let's say in Europe, it's registered for over 12 years. Okay, they can communicate now what the
Sure.
problem they have. For the Frasyroc, we have the problem regarding the renal toxicity.
Yes.
Okay, so it increased the level of the plasma creatinine. Okay, and I mean in some patients they may have some proteinuria as well. However, I mean this is manageable, and the increased level of the serum ferritin is non-progressive.
Right.
So it's increased, but not into a kind of clinical significant problem for the patient.
Right.
So if you follow the registration strictly, I don't think you will have any problem.
Problems. Okay.
Yeah.
Okay, I'm going to finish by just asking you what the role of stem cell transplantation is in sickle cell disease and thalassemia.
Yeah.
Who do you send for transplantation?
Well, that's a very good question, and I know that you are a transplanter,
Well, I was.
right? You're the father of transplantation in Ireland. Anyway, transplantation is very important because let's think about regular blood transfusion, iron chelation for 50, 60 years. It will cost a lot of money.
Sure.
So transplantation is the most effective mean of treating patients with transfusion-dependent thalassemia. So the first thing that we will select only the patient who require such kind of the lifelong treatment, transfusion-dependent thalassemia. We are not transplant non-transfusion-dependent thalassemia, because concerning that we have to balance with all the risks that
you can kill people with
transplant
transplantation.
Absolutely, TRM. You can have chronic
GVHD, very bad,
and also hypogonadism and long-term, problems.
And sterility as
So
well,
it has to be really justified to do it. Yeah.
So
and
for
the
non-transfusion dependent,
we don't do
you
that.
never do that.
We never do that.
Okay.
We have this strict recommendation from the Thailand Society of Hematology. We not do that. And the government, they are not going to reimburse for that. Yes.
Okay.
They reimburse for the transfusion-dependent thalassemia, of course.
Fine.
Yes. And you need to have sibling. You need to have a donor, not always the sibling. You need to have matched a donor as well. And that's kind of, limiting in a way.
Right.
Yeah.
What's the average family size in Thailand? And how many children do people have?
I have only one children.
Is that the normal?
As a normal.
That's the normal. Well, you need to make. In Ireland, we still make babies. Okay.
Oh, very good.
We have the highest,
good for you.
the highest birth rate in Europe. Anyway,
Very good
so
for
babies
you.
are sometimes useful.
Oh, yeah, that's right. The
Anyway,
family size is only 1 or 2 in
One or
Thailand
two.
now.
That's not enough. Not
Yeah,
enough.
not
Okay.
enough.
Thank
All
you very
right.
much indeed. Okay.
Thank you. Thank you very much.
So for you young
Very nice
researchers
talking
out
to
there,
you.
thank you.
Thank you.
There are still issues, and as I say, the spectrum of disease in Europe has certainly changed in the last 10 years with migration from Southeast Asia and from the Mediterranean. So you need to know about how to assess these patients, how to treat them, and what the role of transplantation is. So thank you very much indeed
Thank you.
for sharing your views
You
with
are
us.
very
Okay.
welcome.